Thank you. I appreciate the opportunity. I echo Mike's comments about Dr. Shane's a great resource, and the malignant heme program at Moffitt is outstanding, and we reach out to them a lot for assistance with our complicated patients. And myeloma is difficult to describe to patients. I think solid tumors are much easier for people to conceptualize. A lung cancer, a breast cancer, you can measure it on a scan in centimeters. You can show it when it's getting smaller. You can show it when it's getting bigger. I think it's just easier for people to wrap their minds around these liquid tumors, leukemias, myelomas, and such. Much more difficult for people to conceptualize, and so that's a task we have when we're diagnosing patients, is to get them to have an understanding of what their disease is, and that's certainly a challenge with myeloma. Like any cell in the body, it can become cancerous and begin to replicate and multiply. And as Dr. Shane said, with multiple myeloma, it's the plasma cell. These are part of the immune system, helps make antibodies to help you fight infection. And so just like any cancer cell, 1 becomes 2, 4, 8, 16, 32, and so on. And you end up with too many plasma cells making too many proteins. And this leads to many of the problems that Dr. Shane alluded to. This is not breast or lung cancer in terms of hundreds of thousands of cases a year, but there's going to be 30,000 cases of myeloma diagnosed this year. So it's not a rare entity by any means. It's fairly common. So any oncologist who's practicing, even who's taking care of multiple tumors, as we do in the community, you're going to have a good collection of myeloma patients just based on there being 30,000 cases diagnosed in the U.S. a year. And you couple with that, patients with myeloma, fortunately, typically live a long time. And so you're going to collect, maybe you get a few patients a year, but because they live a long time, in your practice, in any given time, you may have 20 or 30 patients with that diagnosis. And again, Dr. Shane, obviously much more, because he sees, only patients with myeloma. But it's a disease that's very common in the community because the duration that people live so long. So that's a great thing, right? This is a disease that, like everything in life, is a bell curve. The majority of the people in the bell curve, the meat of the bell curve, are living somewhere between 5 and 7 years. Now that's data based on a lot of old drugs. We got a lot of new drugs now. Who knows, maybe those numbers will change over time. But there's some unfortunate people in the tail end of the bell curve who have very aggressive disease and specific genetic abnormalities associated with the disease that have a much more rapid course, unfortunately. And by the same token, like with any bell curve, there's a fortunate few folks in the other end of the bell curve who respond very well to their initial treatment and stay in remission for a long period of time and lead a normal life expectancy. But the majority of people in the meat of the bell curve sort of have that 5 to 7 year time frame, and they oscillate between remission and relapse. And so, the advantage, obviously, of people living a long time is that it's not a immediately lethal disease. The downside of that is it's sometimes difficult to get, information in clinical trials, because patients live such a long time. They often, even if they participate in a clinical trial, will end up receiving the alternative therapy at some point in the course of their care, and it becomes very difficult to prove that one treatment is better than another. So that's the downside of researching diseases where patients live a long time, is it's sometimes you have to wait a long time to get answers. But the importance of participation in these clinical trials cannot be underestimated. I don't know the exact statistics on how many new drugs have been approved in myeloma in the last 10 or 12 years, but I would have to take my shoes off to count them. And the reason we have those is because patients have the courage to participate in these clinical trials. And so I think, we have a clinical trial program in the community at Florida Cancer Specialists. Obviously, Moffitt has a rich program with lots of research studies as well. And the importance of participating in that cannot be, undervalued. It's extremely important. I think patients, when they consider participating in a clinical trial, there's a lot of information to go over. There's a lot of signatures that are required, and I think it gives patients a false sense that this is like a mortgage. This is a commitment. I'm having to sign all of this because I'm committing to participating in this, and I can't change my mind. And And that's, nothing could be further from the truth. We certainly need to dispel that notion. The reason for so many signatures is to make sure the patient's informed and knows what's going on. You can sign, all 35 of these pieces of paper just like a mortgage, and 5 minutes later change your mind, unlike a mortgage, and decide that you don't want to participate in it anymore. You could get in the parking lot and say, you know what, I changed my mind. I don't want to be in this clinical trial. Give me the standard of care. And you don't even have to have a good excuse. And so I just want to, extol the virtues of clinical trial participation. It's the courage of patients who've elected to participate in these trials that has led to so many of these drugs being approved. Even if you're currently being treated with standard of care, at some point those drugs you're on were part of a clinical trial to demonstrate their safety and efficacy. And so that's extremely important. As Dr. Shane pointed out, bone marrow transplant is often part of the treatment for multiple myeloma. We have so many new drugs now that are so effective. There's a growing faction of experts that maybe think that that isn't necessary anymore, that maybe we can get just as long of remissions and just as good of results by not doing the bone marrow transplant. That's certainly not the majority, but I would say there's probably more people that feel that way today than 10 years ago, perhaps. But it's certainly a rock that needs to be turned over. It still has, benefit in many patients, and that's one of the many ways that we enlist the help of our colleagues at Moffitt with our patients with multiple myeloma. They've received their induction therapy, step 1, as Dr. Shane points out, and then we send them up there in consideration for a marrow transplant. And I love your comments about that being a bit of a misnomer. I mean, this isn't someone else's bone marrow. This is your bone marrow. And so you're not looking for a match. You're not worried about rejection. This is a much more straightforward procedure than a bone marrow transplant where you're getting someone else's bone marrow. So again, I think the other way we really utilize our colleagues at Moffitt and lean on them is because there are so many new drugs that have come across in such a short amount of time. No one's clear, and I think that includes Dr. Shane and his colleagues, what the exact, precise, best order and combination of drugs is. And frankly, I don't know that we'll ever know that, because if we were to do a study, looking at that, by the time we would get those results, there would be 6 new drugs out, and no one would care about the question we were asking. There'll be a new question that we need to ask. And yeah. So I kind of think about that when they talk about cell phones not causing brain tumors. It takes years for those studies to mature and get results, and by the time they present them, nobody's using the cell phones that were studied, right? The cell phones change annually, and so 5 years after doing the study, they present the data, but nobody's using the same kind of phones that were 5 years ago. I want to know, what about the phone I'm using today? Does it cause brain tumors? Well, they'll start a new study, and guess what? By the time those results are available, we won't be using those cell phones either. So you're going to be constantly chasing those results, and so it's always helpful to get the opinion of experts in the field who work exclusively with myeloma patients, conduct research exclusively in this disease, to get some guidance as to, what do you think, A, B, or C, or do we go with D, E, and F, or, it's extremely helpful to get some insight and some guidance on that with patients. So we have a good relationship with our colleagues in the malignant heme department, specifically myeloma, and we look forward to continuing that and assisting the patients in the community here and afar. Thank you.